All right. Hopefully. All right, so hopefully this talk will be a subject that's maybe a little easier to figure out how to implement clinically. It doesn't have as many questions. And that is fast MRI scanning using artificial intelligence. And before starting, I have to acknowledge a number of people who really have made this talk possible because of their work. First, Jan Fritz, who is our section head, who's really, I think, an international leader in accelerated MR imaging, who's lent me a number of slides for this talk. Dan Slottickson, Patricia Johnson, and Florian Knoll, who are part of our imaging, Basic Imagers, a research team who really started working on a deep learning acceleration a couple of years ago and have really been an integral part of what we've done. And of course, the entire NYU MSK team, who've spent a lot of time doing interchangeability studies and looking at these sequences to get us where we are today. And just to tell you that this is something that's not just being talked at radiology meetings, but this was a CBS News piece that just ran a week ago talking about breakthrough MRI using AI for faster scans. And this is part of the work we did with Meta in documenting that we could actually do this and be interchangeable. So the question is, why is speed important? The clock's not starting. I don't know if it's supposed to.
It's okay, I'll keep going.
Okay. If somebody could start the clock, that would be great, just to let me know what's going on in terms of time so I don't go over for the other things. So the question is, why speed? And the first thing is increased patient comfort. Patients really like it. So as part of this CBS piece, they actually interviewed patients who said that, it used to be a 30-minute scan, and now we're down to 15 minutes for our joints. And that really made a difference for that patient, and she wouldn't go anyplace else. And it's nice to be able to get patients on and off. Why is that important? Because it also improves image quality. So if any of you have lied on an MR table, it's not that comfortable. I was talking to an MSK person today who said when they had their scan, they were sure they weren't moving, but in fact they were. And there was motion, and motion obviously degrades image quality. It's important for pediatric imaging. So if we can go faster, we can actually eliminate anesthesia and perhaps sedation for a lot of our pediatric patients. One of the things we don't think about a lot in the United States, and certainly in our institution where we have about 60 MR scanners, is getting an MR scan is pretty easy. But if you think about it, in a number of countries, especially LMIC countries, it can be very difficult to have an MR scan where there may be 4 MR scanners for a country of 40 million people. So if we're able to go faster and decrease the cost, it'll allow increased accessibility. And one of the things that I think is really interesting and something that we've tried to do for a long time is it might allow us to change imaging algorithms. So for example, I'm sure all of you have read a lot of plain films on patients in their 20s and 30s who have a sports injury. And almost all of those are negative. And yet we always start with radiography for these sports injuries. And the reason is that it's cheaper and it's faster. You can have a walk-in scan. And I would argue if we can go faster, and my goal is to have 5 minutes of scan time, and hopefully I'll show you that we're doing that now, or less than 5 minutes. So room time can be 10 or 15 minutes. You can really decrease the cost, and it's faster than radiography. Our x-ray slots are 15 minutes. If I can do 10-minute or even 50-minute MR scans, why won't we start with an MR? And I think that would be great to stop reading all of these normal plain films and radiographs on young patients with sports injuries. So this is a slide I learned from Dr. Subhash, who's in the audience and going to speak today. And this is a slide that we used to talk about is why it was so hard and why it took us so long to actually accelerate MR. And that was the algorithm was that if you wanted to go faster, you decreased image quality. And if you wanted better image quality, you had to go slower. It was this trade-off in MR. And I would argue that that's the past. That's no longer true. What I'm going to try to show you in the rest of the talk today is that in the present, not only can we go faster and maintain image quality, we can actually go faster and have improved image quality by using deep learning reconstruction. So again, what we just heard, and what you hear a number of times today in this session, is pattern recognition AI. It gets a lot of the publicity. This is what people think about in AI and radiology. Can AI make a diagnosis for us? Can it detect a fracture? And then what you're doing is in MR, you'd be acquiring your case space, you'd be converting it to image domain, running it through a neural network, and saying, can I make a diagnosis? What we're doing now is something different when we're talking about deep learning reconstruction. What we're doing is we're trying to sample that data differently. In this case, when we started with Meta, we were undersampling our data. So when we looked at case space would be sampling maybe every 3rd line or every 4th line. And then we're taking that undersampled data and we're putting it through a neural network. And the question is, can we get image quality as good as, or has it turned out even better than, fully sampled images when they were reconstructed using standard reconstruction techniques? So when we started, we actually started using undersampling, and I'll talk about that. But now there are other ways of using AI to accelerate. They include denoising and super resolution. And what I'll try to show you is that by using a combination of all of these deep learning techniques, you can actually get incredible image quality very fast. So this is an example of what we did with deep learning reconstruction and undersampling. So you can see when you undersample, we all know that you can get image artifacts. So we know that's a need, but you can see the artifact. None of us would want to interpret that image. What we do is we take that image, and this is with standard reconstruction. We put it through a neural network. We reconstruct the image, and then we compare it to a reference image, which is fully sampled. We then look at a similarity measure. We look at the reconstruction error. We go back and we tweak the neural network. We change the weighting, just like you do for pattern recognition. And we put that image again through it, and we do that multiple times. And this is kind of a schematic reconstruction of how we would do it. Again, starting with this undersampled image, what it looks like with conventional reconstruction. We put it through in the neural network, and the first time we put it through, it doesn't look very good. Nobody would want to read that image as well. But we keep going through it, usually a number of times, maybe 20 or 25 times, until we get an image that really looks as good as a conventional reconstructed image. Now, one of the questions you might ask is, well, how many different types of exams do you have to train this algorithm on? So we know if we're using pattern recognition, you have to have a lot of cases, thousands of cases, so the algorithm can recognize all of the different pathology and anatomy. And you might say, well, how do you do this if you want to use deep learning reconstruction? How do you make sure that it really recognizes the meniscal tear or something else, an ACL tear? And what I'm going to try to argue is that when we're doing this with deep learning reconstruction, we're not learning anatomy, nor are we learning pathology. What we're really learning, or what the algorithm is learning, is to differentiate true image signal from image noise and image artifact. And if that's true, that means that we could actually train an algorithm on images with a variety of different anatomy and different contrasts. And this is what I'm going to try to show you we did. So these are fully sampled images, and you can all recognize them. Here's a fluid-sensitive image of the shoulder, proton density of the knee, a brain, I have to throw in a neuro case, a hip, and an ankle. All right, and now what we did then is we trained a neural network to reconstruct images, but it was only trained on a particular anatomy and a particular contrast. So this fluid-sensitive shoulder was trained just on fluid-sensitive shoulder images, and vice versa, going all the way down the line. And this is the mean squared error, which is really a measure of how accurate that reconstruction is compared to the fully sampled image. And you can see anything close to 1 is excellent. So all of these reconstructions really had excellent accuracy or similarity to the fully sampled image. But if I'm right in that we're not learning pathology and anatomy, but what we're learning is to differentiate true image signal from image noise and artifact, I should be able to train a neural network on all of these images at the same time. And if I do that, I should get images that look just as good as a neural network that's trained on a single type of image with a single type of contrast. And that's this experiment. So all of these images were reconstructed using a neural network trained, as I just described. And if you look at the mean squared error, you can see it essentially didn't change. So in fact, this proved that what we're doing is not learning anatomy pathology, learning image signal, and that really gave us confidence to go forward. And these are images from a paper we published a couple of years ago. This was a retrospective study. And again, thanks to all the NYU MSK radiologists who read hundreds of images to compare these both with conventional reconstruction. This is retrospectively undersampled, and then doing the retrospective undersampling, showing that for 19 different characteristics that we were looking at, meniscal tears, ligamentous tears, cartilage abnormalities, the conventional reconstructed images and the accelerated images using deep learning were interchangeable for every single characteristic or finding that we looked at. What was really surprising, though, is that, first of all 6 of those radiologists, they were fellowship-trained radiologists, chose the accelerated images to be higher and better in image quality than the conventional reconstructed images. And again, that was probably just because of the denoising that was inherent in this neural network. Here's another example, another 2 sets of images. Now, you all can recognize this. You can immediately say this is an ACL patient with an ACL tear. You can see the Sagan fracture. One of these images is accelerated by a factor of 4, and one of these was our conventional reconstructed image. And the question is, can you differentiate? Can you tell which is which? All right? And the answer is our radiologist had a difficult time with that, and in this case, it's the one on the left that was accelerated by a nominal factor of 4. So that's how we started, and then Jan came and joined us. And we tried to go even more and even better. So these are examples of simultaneous multi-slice imaging in combination with parallel imaging. So we have a simultaneous multi-slice with a factor of 2 and parallel imaging with a factor of 2. They add up together, so it's 2 times 2. So this is nominally accelerated by a factor of 4. And this is with conventional reconstruction. And Jan published some papers when he was still at Hopkins showing that this is really accurate. The images look pretty good. But this is the same data, but this time we really use deep learning to reconstruct those images. Looks a little bit better. And then we added super resolution. And now you can see we believe this image has the best image quality, again, with a factor of 4. Here's a proton density image showing a meniscal tear. Again, easy to see that meniscal tear. This is conventional reconstruction. Again, an SMS PAT2 deep learning super resolution image. Here it is with deep learning reconstruction. Here it is now with deep learning and super resolution. And again, these images are a factor of 4 faster, all right, and I think better image quality. So that was good, but not good enough for us. And this is our current knee protocol. These are now, this is on a 3 Tesla machine. They're 6-fold accelerated, so it's simultaneous multi-slice factor of 2, parallel imaging factor of 3, deep learning reconstruction, and super resolution. These are 5 sequences. You can see the sequences. And the time of acquisition, now this is gradient time, so it takes a little bit longer when you do all the other steps in between, is 4 minutes and 5 seconds. So really excellent image quality, incredibly fast, really changed how we can schedule our patients. And when we talk about cost savings, we're at a 15-minute slot now for our joints. You can do a lot more patients in 15 minutes than you can do if you were doing a 30 or a 40-minute knee like we used to. Now you might argue this is great, but this is a knee. A knee is easy, right? Does this technique work on other joints? Well, let's look at a shoulder. So a shoulder is always hard. This is our conventional imaging. Again, this took 1 minute and 44 seconds. In this case, we use deep learning with a factor of 3, acceleration, 1 minute and 14 seconds. Image quality is truly excellent. If you go to a factor 4, again, we save time. Now remember, as you accelerate, you save less and less time because you have central case-based lines that you always have to acquire. So you don't gain the same advantage every time you increase your acceleration. But now we're at 4 times acceleration. I think these are really excellent images. Everybody would accept those. And we're talking about a minute. But still, it's a big joint. What about a smaller joint? So how about fingers? So a lot of you can recognize this patient has a pulley injury. All right, again, 5 sequences, 6-fold acceleration, again on a 3T machine, truly excellent image quality. And this is really standard for what we're doing now. But again, can we go even further? Maybe. This is now SMS2 PAT4, and this is with conventional reconstruction. How many of you would want to read this image? Nobody, right? Nobody wants to read this. Now, some of us are old enough when we used to read off very low field magnets, and this is what we read every single day. This was the best image quality we got. But nobody wants to read that now. We took the same data, we put it through a deep learning algorithm, and that's what it looked like. So we're not doing that yet, and we certainly have to make sure we're not going to miss any pathology and make sure that we're not doing too much denoising, which can small lesions get lost, which we learned. But image quality, that now this took 29 seconds. Now the question is, everything I've showed you so far has been on 2D imaging. Can we do this on 3D imaging? And again, thanks to Jan, these are some slides that he lent me. What we're seeing here are PAT3 times PAT3, deep learning reconstruction, super resolution images. And again, you can see, and I know Avnish is really somebody who's a fan of 3D, but you can see 9-fold acceleration in both proton density and fluid sensitive fat-suppressed images. Really, again, excellent image quality. So I think really exciting potential as we go forward. And so in summary, what I'd like to say is that deep learning reconstruction has been shown now to increase the speed of MR acquisition with preservation and improvement of image quality compared to conventional techniques. We're currently in the middle of a multi-site, multi-vendor trial. We've collected a number of images from different vendors at different sites to prove the generalizability of this technique. And I think what's really exciting is that essentially every vendor has now incorporated this technique into standard offerings on their MR machines. And my prediction is that deep learning reconstruction, if it hasn't already, will soon become the standard for all MSK-MR. And just as an ending, I'm curious, how many of you in the audience are currently using deep learning in your routine clinical imaging in MSK today? in the next few years, the majority of hands are going to be raised because I really think it's going to transform what we do and really allow us to have increased access and much faster throughput for our patients and our scanners. Thank you very much.
Wonderful talk. Any questions from the audience? Okay, I have a question. This was, I think, 3 or 4 years ago when Philips came with their own DL version. And we tried it on neurography, like say lumbar plexus. We could go 18 times, not only 9 times, because there you're just looking for bright nerves. So it doesn't give you good cartilage appearance of knee as such. But have you tried something for the nerves? I think you could go to 18 times.
Yeah, so I can tell you, I don't know that we've done it. I can ask Megan maybe if we're doing any deep learning in one of our MSK radiologists who's in the audience for neurography. I can tell you, though, that we're doing it in other parts of the body. It's not just MSK. So in the brain, we've published a paper that has gone even faster than 18 times. They've gone even faster. They do it for MRCPs, which is really good. So again, I think your point is well taken. It depends on what you're looking for, how fast you want to go, what resolution you really need, what kind of signal to noise you need. One of the real advantages of including SMS to parallel imaging is, as you know, SMS preserves signal to noise, right? So if you combine SMS and parallel imaging, you save some signal to noise, but you get that same acceleration factor because of the multiplication of the SMS and the grappa that we're doing.
Great. Well, thank you so much. The next talk we have is from Dr. Subhash, and this is AI in clinical practice, a different perspective. So his perspective is, does it increase efficiency or add more work?